Hello, and welcome to this CADASIL Care webcast. This series is hosted by cureCADASIL, a nonprofit 501c3 organization dedicated to finding a cure for this rare genetic disease. We'll be talking to various experts in the field of CADASIL, bringing up topics of interest from patients and families. My name is Nancy Maurer. I'm president of cureCADASIL and have been a CADASIL patient advocate since 2014. Today, I'm pleased to introduce Dr. Swati Sathe, who will be sharing information with us today about CADASIL and migraines. Dr. Sathe is a board-certified neurologist with subspecialty training in neurogenetics. She received her medical degree, followed by a residency in internal medicine at the University of Mumbai. She went on to do a neurology residency, fellowship in neurogenetics, and a master's degree in clinical investigation at New York University. She is currently director of neurogenetics at Northwell Health in New York. She has extensive experience in evaluating, diagnosing, and managing patients with inherited neurologic and metabolic disease. Dr. Sathe's primary research interests are in enhancing awareness and early diagnosis of rare disorders and exploring the natural history, especially as it relates to endpoint development for clinical trials. Dr. Sathe has participated in numerous clinical trials related to lysosomal storage disease and also served 2 years at a biotech company as director of the Pompe Clinical Development Program. She is well published in her field and regarded as an expert in genetic neurologic disorders. Dr. Sathe has been on the scientific advisory board for cureCADASIL since 2013. She submitted a proposal to the ICD-10 Coordination and Maintenance Committee in 2016 that was reviewed in March of 2017, leading to the addition of a CADASIL-specific ICD-10 CM code that became effective in the US October 1st, 2018. We appreciate your dedication to CADASIL and your advocacy on our behalf. Thank you, Dr. Sathe, for joining us today.
Thank you, Nancy, for the kind introduction, and it's a pleasure to be giving this webinar on migraine in CADASIL. I hope it serves the larger CADASIL community in getting some pointers towards the causes of migraine in CADASIL and management of migraine. So I'll just start with the overview of migraine. There is about 28 million people in the United States that suffer from migraine. That's a little bit of a setback for CADASIL, because to think of CADASIL as a condition when a patient presents to the neurologist with a history of migraine becomes a little difficult, given how overwhelmingly migraine is common. And in this presentation, we'll try to go over situations or conditions which would lead a neurologist or even the patient to consider something more than migraine as a possibility. In order to diagnose migraine, a patient must have at least 5 episodes of headache, and those headaches need to satisfy these criteria. So at least have 2 of these criteria. They have to be unilateral in location, throbbing in nature, worsening with routine activity, and they have to be moderate to severe in intensity. And then at least have one of the other features, which is nausea or vomiting, and either photophobia or phonophobia, which means either aversion to light or aversion to sound during the episode of headache. A lot of patients in general population may actually have migraine but have never seen a physician, mostly because their headache is relieved by just a pill of Tylenol or with some Motrin, and they do not necessarily seek attention. So only patients who have more severe migraine or frequent migraine are the ones that end up seeing physicians for their condition. Just wanted to give a pointer on tension headache as to how it differs from the migraine headache. So it's usually not unilateral. It's on both sides of the head. It is more of a pressing, tightening kind of a pain as against a pulsatile or a throbbing kind of a pain. It's usually not severe in intensity, and the activity doesn't aggravate it. But one of the most important things is that there is no nausea or vomiting usually associated with tension headache as it is associated with migraine. And there's usually no aversion to light and sound. Now, in CADASIL, when we talk about migraine, there are 2 conditions. Either there's migraine with aura or migraine without aura. Migraine with aura means that prior to the onset of headache, there is some kind of a premonition that a patient gets that the headache is coming on. And this premonition may just be a feeling, but more often it is a particular light or a darkening of the visual field or some kind of a visual aura, or even aura of a feeling that they're going to get the migraine. The aura usually uh, kind of stays the same with a particular patient. It may vary in intensity, but a patient can tell with that feeling that a big headache is coming on. The aura precedes the migraine by minutes to sometimes and up to an half an hour, 45 minutes. And usually, when the headache begins, the aura tends to dissipate or tends to go away. The headache in migraine typically lasts for hours, more than 2 hours, 4 hours, sometimes up to 24 hours. And then each patient knows what's the best medication that kind of works for their migraine. There are some triggers for migraine, such as the common known triggers are not sleeping well, not eating well. There is a trigger with MSG that is used in preparations such as Mexican food or Chinese food. And then red wine is considered to be a trigger. Some people consider chocolate to be a trigger. And there are other food triggers that might be specific to certain patients. Now, with that backdrop of migraine in general population, we are going to talk about migraine in CADASIL. So this is a picture or a diagram that shows when at different stages in life, uh, different characteristics or different symptoms of CADASIL may begin or how long they're supposed to last. So if a person gets an MRI done for an unrelated reason without having any headache or any other reason, we may actually find some MRI findings in CADASIL even before the onset of any symptoms or even before the patient knows that there is any medical condition. Apart from that, the migraine typically begins in teens or late teens and will persist to the age of 40, and we'll go over the details of this migraine. One point to note here is that as patients start experiencing stroke-like episodes or ischemic strokes, the migraine kind of tends to abate, and that's something I've seen in my experience as well. In this particular diagram, the mood disorders are shown to be starting at around the age of 40, but I would say there are certainly patients who have mood disorders well into their 20s, and therefore that could move a little bit to the left. And as time goes by, there are other changes such as a personality change or change in, energy or enthusiasm, so more of an apathy. Eventually, the strokes may lead to some motor disability, so weakness on one side or both sides, and eventually difficulty with executing ideas or difficulty with executive dysfunction, what is typically known as inability to say multitask or inability to organize things more than pure memory or pure language involvement as is seen in Alzheimer's. So there's a little difference in how in the memory issues in CADASIL versus other forms of dementia. Now, in CADASIL, migraine with aura is more common. Not to say that migraine without aura cannot occur, but migraine with aura is more common, and that may be relevant as we go over the pathophysiology of migraine. It's usually the first symptom. The average age of onset is between 20 and 25, but well into the late teens is also possible. Now, initially, this migraine is similar to the wild type. Wild type migraine means occurring in general population. So as we saw the criteria, it is unilateral, it is throbbing. People may get frequent episodes. They usually have an aura associated with it, difficult nausea, vomiting, aversion to light or aversion to sound. In my experience, as time goes by, the migraine becomes more frequent and more intense. And then there are definitely reports from patients that at some point their migraine will become different from the common type of migraine. Now, when migraine occurs in general population, it certainly in anybody the migraine can get more frequent and more intense. It also depends on the lifestyle. It depends on the stresses in life, and all of those do affect the occurrence of migraine. But patients with CADASIL may have something atypical or different than what patients in general population may not have associated with migraine. Uh, so we will go over those atypical things. Now, some of the things that are also known for migraine in general population is they can get weakness on one side of the body associated with the migraine, or they may have episodes of severe dizziness, vertigo, feeling of passing out, or prolonged aura. So all of those things are also known in general population, but they certainly occur with higher frequency in patients with CADASIL. So we had looked at data from 50 patients in CADASIL, and at that time we found that the average onset, if you combine symptoms of stroke or migraine, then the average age of onset is about 36 years. But in this particular study, headache was reported at average age of onset of 25 years. So you can see that 64% of patients reported that they had headache, and then 52% of patients reported that they had a stroke. But again, the age was only 52, the average age, so we perhaps got a little younger population. And if you look at the average age of diagnosis, it was 49 years. So clearly, even from this preliminary study, there is at least a decade worth of delayed diagnosis in CADASIL based on the questionnaire study. So we talked a little bit about migraine with aura. Uh, aura is a warning or a premonition that the migraine is going to come on. The most common aura that we know is a visual aura, but of course there are different kinds of aura. Sometimes people feel tingling, paresthesia, not feeling right, numbness on one side of the body. Now, classically, the aura is on one side of the body, and usually not on both sides. Um, there can be motor aura where you have weakness and clumsiness of one hand. I certainly know one patient who had difficulty, for example, turning doorknobs or using keys or doing fine motor movements with her hands during the episode of migraine. And then some people can get an aura in terms of language where they have difficulty producing speech. So they know what they have to say, but they will not be able to come out with the right sentence or the correct grammar for that sentence. So all of this can be seen in general population, is certainly seen in patients who have CADASIL and have migraine. So what is not unusual in CADASIL? So this patient I'm going to talk about, he is the one who first directed my attention to this unusual phenomena of acute confusion migraine, as I've labeled it here, in CADASIL. And at the time when we saw the patient, he was 42 years old, and he had his whole medical history began with his first stroke episode that occurred at the age of 34. And I have put his MRI scans below. Now, if you look at this scan, this MRI is taking a cut from the brain. If you look at the most right picture, then you can see the orbits, or you can see the eyes, you can see the nose, and this is the back of the head. And that's a cut taken from, say, from the eye or the nose level to the back of the neck. And then the cuts on the left side are going higher and higher. So you no longer see the ears or the eyes because you're on the top part of the brain and the cut is taken horizontally. Now on this particular slide, all those dots that appear to be white, and I hope you're able to see my pointer, all those dots that appear white are not supposed to be there, especially for somebody who's 34 years old. We are not expected to see the white spots that we are seeing. Now, given this MRI, he was diagnosed with MS and he received therapy with immune modulating therapy for a few years. But what's very unusual, and which was there right from the beginning, is this white matter change in the very front part, right behind the ear. And that's very unusual for MS. Even having it on one side would be unusual, but having it on both sides is certainly unusual. And that involvement is supposed to be quite diagnostic of CADASIL. It was described by Dr. O'Sullivan, who was a radiologist from the UK, and can be called the O'Sullivan sign. So that should have prompted a diagnosis of CADASIL in this patient years ago. But in any case, when we saw him first, he was already 42 years old, and he had had few more episodes of this left-sided weakness. But of course, when you take history in the back, and hindsight is always 2020, he did have history of migraine aura since his 20s. And he told me that after a few years of having the migraine, he would get an aura in such a way that he would actually avoid, say, going out of the house, or if he was at work, he would have his co-workers drop him back home, and it lasted for about 2 hours. And I said, why is that? And he said that's because he gets kind of confused when he is having this aura. He can't tell exactly which way to go home, or when he's driving, he's not able to say if the stoplight says go or the stoplight says stop. And so he had difficulty with finding direction, and then sometimes was able to know people. He knew that he was supposed to recognize them and not recognize them. Following this, which was very unusual and which was a very striking finding, we went ahead and asked, I haven't put that paper up, but we went ahead and asked at that time we had about 20 patients of CADASIL, and we went there and asked all of them whether they experienced anything like this. And 12 of those patients said that they do have these kind of confusional episodes with the migraine. Uh, so we called it acute confusional migraine. It is a described entity in children, but adults in general population who even have the severe most kind of migraine usually do not have acute confusion during the migraine as reported to us by the CADASIL patients. Other things that were reported to us were there was a patient who was a car mechanic, and he said he couldn't tell what instrument to exactly use while he was doing his job. During that period that he had aura and headache, he couldn't pick out the right instrument to use. One patient told us that when she enters her building, she can't tell whether her apartment is to the right or to the left. Sometimes they said they get in a cab and they can't exactly tell the cab driver which way they are going or what address they are going to, despite the fact that they know exactly where they want to go. So these are the kind of things that do occur with patients, and as the aura passes away and the headache begins, this confusion kind of resolves. Now, there are other descriptions of unusual findings during migraine, and one of the other papers was CADASIL coma, where a seemingly small infection or a seemingly small alteration, otherwise, say anesthesia or something, will lead the patient to have severe encephalopathy, meaning that they'll become very drowsy, very lethargic. Younger patients usually do not do that for small changes, but turns out that in CADASIL, even with small changes, sometimes patient may have big changes in their mental state that they may become very lethargic and obtunded for a seemingly small cause. This is reversible. I don't want to scare anybody. This is reversible. It passes. But this occurrence of sudden change in the mental status, even with a small change, may be an indicator for diagnosis of CADASIL. And as I said, as the episode passes, of course, patients get back to their normal mental state. And then again, other papers where acute headache with a very focal finding, more than the hemiplegia or more than just the language, more involvement has also been described. So these are some of the unusual features of migraine in CADASIL. In my experience, as time goes by, especially in their 30s, patients do have significant morbidity with the migraine in terms of the frequency of the attacks or the unusual phenomena that they get with the aura of the migraine or during the headache of migraine. Now, what do we do with migraine? Now, as far as we can say at the moment, the treatment of migraine in CADASIL has got to be the treatment of migraine. Otherwise, there is no reason to believe that we have to treat patients differently or evaluate patients differently. There may be some medications which can be used and some medications that may not be used for patients of CADASIL, and that we will go over that. Now, in general, like I said, there are a number of patients in general population who may never see a doctor for their migraine because their migraine is too mild. They may get 1 or 2 episodes a month and they take Motrin or any other pain medication that works for them, except in migraine, and they do not have to see a doctor. So we never be able to know the true prevalence of migraine in general population, given that a patient usually seeks treatment when the migraine becomes severe or starts interfering with their daily routine. For such, it produces more than 3-4 attacks a month, and those attacks last more than 4 hours, 6 hours, sometimes a day. Or sometimes people have maybe just 1 attack a month or 1 attack every 2 months, but that attack lasts 2 days, and that will also bring a patient to medical attention. So we do not have to use medications other than the commonly used medications unless there is a reason for it. So of course we give a trial with common medications such as ibuprofen or naproxen, sometimes even Tylenol, and see if that helps. We have to make sure that we are not overusing these acute medications, because there is a phenomena called rebound headache, where if people start using these acute medications more than 4 times or 5 times a week, then eventually withdrawal of those medications or not using those medications gives them a rebound, and they go into this cycle of rebound headache, use of medications, and that's certainly something that we would like to avoid in any migraine. And also in special circumstances, like I said, when you have hemiplegic migraine, when there's weakness on one side, or the language, where language is impaired, that's certainly very concerning for the patient, and as much as possible, we would like to avoid those kind of attacks. So with all of those reasons, we have we address patients' requirements depending on the frequency and intensity of the migraine, and sometimes even what the patient might be doing as their profession. So if you, for example, have a teacher, then you can imagine having more than 2 or 3 attacks a week can be very disabling for her, especially if she has to have manage a classroom of rowdy students. So that patient may need more attention as to somebody else who may have a more sedentary job and is able to take time off and come home and lie. Uh, they may have a different preference for medication. So profession and other daily activities do play a lot of role in what medications we may choose. So for any chosen medication, we would like to start with the lower drug. Now before that, uh, so there are two ways to treat a migraine. We use something that is acute when the patient does have migraine now, and they get the aura or they feel the premonition or they know they're going to get a headache. There's something that they need to take at that time to prevent the attack. And the second way of treating migraine is introduce a medication that is taken on a regular basis all the time to prevent a big attack from coming. Now, again, the same principle would apply whether to use a preventative medication or not. If the if the frequency of migraine is not that frequent or if the attack is not that severe, we may not choose to use a preventative medication. And in some other cases, we will choose to use a preventative medication. Now, when we are using a preventative medication, we have to remember that we are using something to prevent an attack of migraine for coming. So we always have to have the benefit more than the risk involved in taking that medication in terms of its side effects. So we always want to use a low dose medication that has the least amount of side effects in a particular patient or a patient group, and then that the adverse events are not intolerable. Then of course you do not want to use that medication. So for each of these preventative medication, the most important thing is that we have to give an adequate trial. These are preventative medications. They do not work in 5 minutes or 5 days. Sometimes they need 3-4 weeks of trial to say this particular medication is not working. And if there is some response but not total response, we can always try to increase um, the dose of the drug a little bit and see if that gives a good response. Now the goals also have to be realistic. Most of the times it is said that if there is a 50% reduction in the frequency of migraine, that's a good outcome for that medication. So again, 100% reduction in the frequency of migraine may not be possible at all times, so that the goal has to be realistic. And again, in terms of adverse event, we have to see what we can give and take, what is acceptable to a patient. The role of the preventative therapy is to avoid use of those acute medications over time and make them into the cycle of rebound headache and make them dependent on those medications for acute headache. That's the role really of preventative medication. If the preventative medication works, if the migraine is under control, we have to go back and say, okay, at some point we might be able to take the preventative medication away, lower the dose, and so on and so forth. Very high caution in women of childbearing age group, and we have to consider whether there's a pregnancy planned. And of course, if the patient woman finds out that she's pregnant, she should contact the doctor immediately to see what can be done with the drug, if it has to be stopped or changed. And the best way sometimes I say to see if a preventative medication is working is to actually maintain a headache diary, because it's sometimes difficult for the patient to say if they had a headache 2 weeks ago or 3 weeks ago. That way, if you have marked in a diary or a calendar how many attacks and what was the intensity of the attack by using, 3 points for high intensity, then we know if a particular preventative medication is working or not. So again, we talked about this. Abortive therapy is something that you take acutely. Preventative therapy is something called as prophylaxis. Now, abortive therapy, as we discussed, could be something very simple: aspirin, ibuprofen, naproxen. Any of those are good. Sometimes the patient comes to an emergency room, then they get ketorolac, toradol, as it is known, as a IM injection for used for prevention of headache. I have to say that most of these migraine medications are really used based on experience by the doctors. There is not much of evidence behind each of these medications to support their use in migraine, and there is a if there's interest, we could circulate that particular document that comes from the American Headache Society regarding the support for use of these different medications in migraine. A lot of people use Tylenol. Again, it says that it has not been found to be effective. I think it's because people who do respond to Tylenol probably don't see a doctor, and therefore uh, we may say it's not an effective therapy, but of course we know a lot of people who will take Tylenol for their or acetaminophen for their headache and get some relief. I apologize for the use of trade names. They're just coming to me as I'm speaking. So wherever possible, I will revert back to the drug name. Opioid analgesics are used. Again, a big caution for their use. They have to be closely monitored for dependence. They are, in general, not the best medications for headache, at least in my experience. And we have to be very careful with overuse and rebound headaches with them. There are some other medications that are antiemetics to prevent vomiting and nausea, and they work pretty well in migraine. Sometimes when patients have migraine, continuous migraines or continuous headache for a few days, sometimes we do use steroids to break a migraine, and that again is a very popular mechanism of therapy. Again, I have to say that there's not much evidence for it. There haven't been several trials for it, but by general experience, they do seem to work. And then there are some specific therapies for migraine. The first that came were ergotamine, and then the newer ones called triptans, and there's a whole bunch of them. Uh, you know, very commonly used for migraine. These are not generally recommended for patients with CADASIL because they do work by a mechanism where they narrow the blood vessels. Now, I have not come across an actual report that says that if you use triptan, the patient did end up getting a stroke. But by common wisdom, if there is a person who has an increased risk of stroke and these specifically constrict the blood vessels, then you would much rather use other medications that do not have this side effect. And overall, even in other patients who have not CADASIL, but other migraine patients who have the hemiplegic migraine or the basilar migraine, generally triptans are not recommended. There is another medication called Fioricet, which I don't think I put here. And that's again a very old medication. It has acetaminophen with caffeine and some butalbital in it. Has been used for, I think, over 40, 50 years. Again, it's a good medication for acute prevention, but does have the threat of having rebound headache, and therefore it's common wisdom not to use it more than 3 times a week, and that's usually how it is prescribed. But that's another medication option for treatment of acute migraine. Now, there are newer medication called calcitonin gene-related peptide blockers, and those specifically block the vasodilatation or the opening of the blood vessels that occurs during the attack of migraine, and that is supposed to cause the acute gush of headache and the throbbing nature of the headache. And these compounds block that gush of dilatation. In that sense, again, I think we need some more experience because though they don't necessarily constrict or block or make the blood vessels narrow, and if they're only preventing it from becoming bigger and preventing the gush of blood, I think they might be okay. But I think we need some more experience. They were recently approved, and so we really don't have much experience with them. Definitely not much experience in CADASIL to recommend or not recommend their use. So again, this is just a general premise for who should be considered for abortive therapy and who should be considered for preventative therapy. And the goals of the therapy are to reduce the frequency and intensity of the attacks. A lot of education about what may trigger the headache, regular sleep, meal schedules, and then drugs that are known to cause headache or known to precipitate headache should generally be avoided. And like I said, for the beneficial effects of prophylaxis, it may take some time, may need definitely a month or sometimes up to 2 or 3 months to see if they are working or not. There are a lot of preventative medications. Again, not much clinical trials or not much evidence-based, but really experience-based. And they come from all different classes of drugs. So some of them are blood pressure medications or beta blockers like propranolol and atenolol and verapamil. Some of them are antidepressants like amitriptyline. Some of them are seizure medications, or a number of them are seizure medications like disodium valproate and topiramate, gabapentin. So a number of they come from different groups of medications, and they were secondarily found to reduce headache just by experience, and they became established as medications for prevention of headache. Magnesium and riboflavin are also known to reduce headache. Sometimes I'm a little biased to them, mostly because even if they offered some benefit, if not perfect benefit, but there is hardly any adverse event related to use of riboflavin, which is actually vitamin B2 and magnesium, and therefore whatever benefit they may offer is without any adverse event, and therefore it always is in the favor of benefit. And I do favor those even as an addition. So if I'm using, say, gabapentin, I may just use magnesium as an addition to prevent headache. Again, the use depends on a particular patient. For example, somebody has asthma, we're not going to use a beta blocker. Somebody has other contraindications to use as an antidepressant, then we won't use that. So they have to be tailored to a particular patient and to a particular situation. There is no medication that can be just recommended across the board. I hope that summarizes the picture of CADASIL as it appears, picture of migraine as it appears in CADASIL, and some steps for managing patients with CADASIL. I do want to thank CADASIL Association for this opportunity to have a dialogue with CADASIL patients. And I will turn the mic over to Nancy now for some closing comments.
Thank you, Dr. Sathe, for this insightful presentation on CADASIL and migraines. We appreciate you sharing your knowledge with us today. And CADASIL Care is made possible by volunteers of cureCADASIL, generous donations from CADASIL families, and a grant from Global Genes. This concludes our presentation today. Thank you for joining us.